This lecture will cover special patients that you're going to find as an EMT. The extremely young, the extremely old, some special advanced type of disease processes where patients are on high-tech devices that you're going to have to incorporate into your overall patient assessment and care. So when we talk about special populations, newborns, children, and the elderly, all of the issues that you have with their care and treatment. Now, most pregnant patients are healthy and their gestational period is normal, but during the course of this 36-week gestational period, things can happen. They can get ill, they can have chronic conditions that can contribute to complications. One of the most common is pregnancy-induced hypertension. Pregnancy-induced hypertension is a serious cardiovascular disease that can also cause preeclampsia. Preeclampsia is, in short, the body having a reaction to the fetus. It's not your normal anaphylactic reaction, but it is a reaction nonetheless, and it's a cardiovascular response. We have increased blood pressure, and in severe cases, it can become eclampsia that can lead to seizures. This develops usually in the 30th week. And really the only way to cure eclampsia and preeclampsia is through delivery of the fetus, removing what the body is reacting to. So we obviously don't do that pre-hospitally. So what are we going to do as far as assisting this patient? Left lateral recumbent positioning is probably the best. Making sure you have an open airway, giving good oxygen, suctioning if needed, and call for ALS, because if the patient suddenly has eclamptic seizures, the only way to really treat that is with medication that paramedics carry. The most important thing to take away from this slide is that you've got to keep the patient calm. Don't provide a setting that's going to bring on stress. Don't have lights on in the back of the ambulance. Maybe dim the lights down. Lower your questioning. Use a softer tone of voice. Try, unless it's a true emergency, to restrict siren usage. It can cause stress and possibly trigger an eclamptic seizure. In addition to cardiovascular issues with hypertension, we also have endocrinological issues, like gestational diabetes. This is basically the body is insulin resistant and ends up building a lot of excess sugar in the blood. And once again, how are you going to treat this? Just like any other diabetic. You got to look for things like ketoacidosis, like Kussmaul's respirations you have with that. So support airway, breathing, and monitor circulation. Now, bleeding can occur in pregnancy. It could be a normal part, especially if the water broke and we're starting the stages of labor, but we can also have an abnormal or even a serious life-threatening emergency like an ectopic pregnancy. So an ectopic pregnancy, it's a pregnancy that's developing outside the uterus, most common in the fallopian tube. It's very common in women who have missed a menstrual cycle and they have a sudden complaint of abdominal pain, very, very sharp, severe abdominal pain. And you can see this graphic, what's happening is the fallopian tube, which is very narrow and can really barely support an unfertilized egg. Now we have a fertilized egg that is growing inside of it. This can lead to rupture, internal bleeding, and shock and death. Other bleeding we have is abortion, either spontaneous or elective. But abortion is classified as passage of the fetus before 20 weeks gestation. So we want to assess these patients because they're going to be bleeding, make sure that they're not showing signs of compensatory shock. Narrowing pulse pressure, like blood pressures of 120 over 100 tachycardias, right? So if we see that, we know that there's internal bleeding going on more than just what was caused by the abortion. We need to administer oxygen, treat them for shock, transport them promptly, and consider going to places like a trauma center where they're going to need surgical intervention. There are issues that can occur during gestation. A sudden tearing away of the placenta is known as an abrupto placenta. And the placenta itself is an organ that's shared by fetus and mom. And this organ is where gas exchange takes place, nutrient exchange. So it's important to understand that the fetus and mom do not share blood. There's a fetal blood supply and there's a maternal blood supply. But what they do share, and the placenta, is the ability to exchange oxygen, carbon dioxide, and nutrients like sugar, proteins, and water, things like that, that help gestation of the fetus. This organ, the placenta, is very vascular. It is rich with blood. If it suddenly tears away, we're going to have incredible hemorrhaging right there at the tearaway site. And if you look at the graphic, and what I want you to focus on is the area of hemorrhage, you can see that blood is beginning to collect there, but it's not going anywhere. So we may not see vaginal bleeding right away, but what patients will complain of more often than not is a sudden tearing. Now it can be brought on by fetal movement, but also through blunt force trauma. Emergency care includes emotional support, recognition that it exists, get them to the hospital, give high concentration oxygen. So that could be a otherwise normal gestational, normal pregnancy, and suddenly something went wrong. They need to get to the hospital as soon as possible. Now, placenta previa, if the patient is receiving menstrual, they're receiving prenatal care, they should know the location of their placenta. And a placenta previa is a misplaced placenta. And you can see in this graphic, the placenta is actually covering the cervix. So this child is not a candidate for vaginal delivery. Instead, they're a candidate for a C-section. Scheduled C-section, yes. Now, if suddenly the child, let's say, the fetus kicks at the placenta and pushes it through the opening, then we have another problem. A placenta previa won't have that painful response, that tearing away that you would feel with a abrupto placenta, but there'd be a lot of bleeding and it would be painless. So a sudden onset of painless bleeding, the patient tells you that they're scheduled for a C-section, they may not understand the term placenta previa, but you can pretty much guarantee that that's what it is. This is a true emergency. This C-section is no longer scheduled. It's now going to be an emergency C-section because it can lead to fetal death if left untreated. So trauma in pregnancy, unfortunately, is very common. It could be something benign, like a fall. It could be accidental, like a motor vehicle crash, but it can also be intentional. You need to understand that a pregnant patient, women have 30 to 50% more blood in their bodies when they're pregnant. This increased blood supply is due to the fact they have something growing inside of them and they need to share nutrients. One of the side effects of this is that they stay compensatory and don't show signs of shock for longer periods of time than they would normally. So what does that mean? If they're a victim of trauma, car accident, they're not feeling any of the signs of compensatory shock, they can still be bleeding internally and you wouldn't know it. It would take hours. So these patients need to be assessed. Higher risk for internal bleeding, and with more blood circulating, fewer signs of compensatory shock. Cardiac arrest, we follow the same guidelines as a non-pregnant patient. The best way to assure the best fetal outcome is to treat mom aggressively. Good CPR with good ventilation, aggressive advanced life support will be able to keep the baby alive. If you keep mom's circulatory system going, then the gas and nutrient exchange will take place at the placenta. So aggressive CPR, rapid transport. Now, if we're having to assist in a delivery, there are complications. A very common complication of delivery is something known as PROM, or premature rupture of membranes. Now, this means that you have a rupture of the amniotic sac about an hour before actual labor. Now, the problem with this is that while encased in this fluid sac, the fetus is not triggered to breathe. But once the fluid is gone, the child may be more susceptible to take that first breath. And we want that first breath to obviously take place outside the body instead of inside, because there's no air supply in the uterus. In addition, with this, the child starts moving more. There's an increased possibility of cord compression, so there's less oxygen being delivered from the placenta to the baby. Other complications we have, substance abuse. If you know that this patient has a history of substance abuse, the child will basically have that same substance in their body. It crosses over. So they may be at risk for hypoventilation. You need to attack their respiratory. When you have an onset of labor to delivery less than 3 hours, that's known as a precipitous birth. Treatment includes immediate transport. There's a problem with this pregnancy. High flow oxygen, request ALS. It's very possible that this child is going to be delivered stillborn. Be very careful. Get this patient to the hospital as soon as possible. Now, post-term pregnancy, lasting greater 42 weeks gestational period, now we can have some structural issues with the child. And the child is so large that it can cause structural damage to mom. In addition, the baby's going to be more prone to take that first bowel movement. That's known as meconium. A baby can actually inhale that when they take the first breath, that bowel movement. The best way to describe what meconium looks like, it looks like that green wasabi mustard you get with your sushi. Okay, so if the baby comes out covered in wasabi mustard, it's not sushi, that's meconium. That's something where you need to be prepared to resuscitate this child. Sometimes during gestation, the child dies, but the body does not sense the child's dead and does not begin the process of spontaneous abortion. And what we have inside the uterus is now dead tissue. Bleeding is going to be normal during the delivery process, but there is a certain amount that's normal. Once you go over 500 cc's, 500 milliliters, that's deemed excessive bleeding. And that can be caused by a whole list of things that we're not going to be able to know about as EMTs. We just need to know that it, in fact, is occurring, okay? And what we need to do is help mom by massaging the uterus, the fundal area of the uterus, the abdomen, okay? Cover the vaginal opening with a pad. And the massaging of the fundal region can actually reduce the uterine contractions and stop the bleeding. This, in extreme situations, if you're extended to the hospital, you'd want to get advanced life support, because some regions, paramedics carry medication that can stop uterine bleeding. Another postpartum complication after the baby comes out is a pulmonary embolus. Once again, we've got more blood, more circulating blood, okay? And this blood, when mom is now sedentary, the blood begins to get a little stagnant and it can clot. And this clot can easily move up and go lodge itself in the pulmonary arterioles, where you end up having an embolus. So patients will be complaining of severe shortness of breath. They've recently had childbirth, you have to think this is a pulmonary embolus, and rapid transport is required. So it's important when you make a delivery, never forget about mom. There's a lot of things that happen with mom, but during the process of fetal delivery, the birthing process, your focus is on assisting mom in delivering the child, okay? And when the delivery is made, you make sure the head presents. You've got 30 seconds between contractions. Once the head presents, to decide whether the cord's wrapped around the neck. Can you remove the cord that's compressed around the neck? 30 seconds is a long time. If it's wrapped around once, you can easily remove it. If it's wrapped more than once, that's going to be very hard to manipulate. So at that point, once again, you got 30 seconds, you want to clamp and cut before the next contraction. You don't want that baby coming out with the cord wrapped around its neck. Now once the child comes out, this is now a neonate, goes from fetus to neonate. Newly born or neonatal patients they're going from a liquid environment to an air environment. Their lungs were not being used. The right side of the heart was not being used. There's no pulmonary artery blood flow, and there's no pulmonary vein coming from the lungs back to the heart. Why? Because they were getting their oxygen from mom. So oxygenated blood was dumping into the right atria, going across to the left atria through the foramen ovale, and down the left ventricle and circulating around the body. Once the baby takes a breath, everything changes. The atmospheric pressures inside the thorax change with the air introduction. So the lungs, for the first time, fill with air. That normalizes pressure on the right and left side of the heart. That normalization of pressure closes the hole, that foramen ovale. And now blood from the right atria goes down to the right ventricle like it's supposed to do. And it gets pumped to the lungs, where the newly inflated lungs with the alveoli have opened up, filled with air, and we've started the process of life outside the womb. This is the goal of neonatal resuscitation, because once that kicks in, once the baby takes that first breath, that's when everything else falls into place. So our goal as EMTs is to get that kid breathing. That's an important factor. And the best way to get that kid breathing is tactile stimulation. 95% of the time when the baby's delivered, just the action of drying, warming, rubbing will cause that trigger to breathe. The extreme temperature changes. They're going from 98.6 to 72. That 26-degree drop in temperature suddenly will have an effect on this child, and they will take that first breath. If not, you stimulate them with tactile stimulation. They're not used to that either. Triggers a breath. If that doesn't work, then after 30 seconds of that, blow by oxygen around the face. If that doesn't work after 30 seconds, BVM. Once again, we're trying to get the child to breathe. If the child is still not breathing after BVM, and the heart rate has dropped, is not gone above 60, we're going to start doing chest compressions. It's all in an effort to get this child breathing. Because once they start breathing, everything is going to take over from there. So we want to do, if we have to, if the tactile stimulation and the blow-by oxygen and the BVM isn't working, we're going to start doing compressions at a rate of 3 compressions to 1 breath. So when we think about resuscitation, it's all about getting them breathing. Do you have to set up a BVM to supplemental oxygen? Not only does it take too long, but the new guidelines tell you you don't have to. You just want to stimulate this kid so they start breathing on their own. We even fall back with suctioning. We don't want you to think about suctioning right away. We just want you to start the breathing process to trigger it. If the child is, if you think that the child has come out and the reason they're in cardiac arrest is not because they haven't taken that first breath, then we immediately flip into the 15-2 compression ventilation. So if the child comes out stillborn, then we go into CPR. Because at this point, it's not about getting that child to take a breath. The difference we see is there's no presence of a heartbeat at all. The child's going to be bradycardic because they're hypoxic, and so we want them to breathe, and once they start breathing, the heart rate's going to go back up. But if they don't have a heartbeat, then we treat them as if they're in cardiac arrest as an infant, 15-2. There should also be a delay of at least 1 minute before clamping the cord. If you deliver the child, and the child's fine, is crying, everything, wait a minute to clamp the cord. And the reason why is we want to actually get more blood into the fetus. It reduces fetal anemia because you've still got that big supply of fetal blood that's at the placenta that's waiting to make it across. So wait about a minute after delivery to clamp the cord and cut it. So now neonates grow into infants after the first month, and after the first year they become children. And children at the age of 2 begin developing that sense of self. The ego is developed, and the best way you can tell at the age of 2 or 3 that they've developed the ego is they learn to say one word, and that word is no. That is the way that you determine self. No, I disagree with you. So children start going through emotional and physiologic changes at the same time. Very, very challenging to us as EMTs. Everything is sensitive. The respiratory system is sensitive. Very common to things like bronchiolitis, inflammation of the bronchioles. A year of symptoms of bronchiolitis will give that child a diagnosis of asthma. So it takes a year for symptoms to continually happen for a doctor to diagnose this patient as having a reactive airway disease. But in addition, they're very prone to infection. They put things in their mouths, and they can have foreign body obstructions, all right? And they are risk takers, and they fall, and they're susceptible to trauma because their bones are not, while they're formed, they're not developed, and they're more pliable than an adult bone, so they're not as protective. The circulatory system, the takeaway from this is they don't show classic signs of shock like you would find in adults. It's very hard to take a blood pressure in a child under the age of 3. They don't really mean anything. They're 70/30. There's no way to make a determination that this patient is in any form of shock other than capillary refill. Capillary refill is the gold standard to test for pediatric perfusion. With the nervous system, it's very sensitive to changes in temperature, to a feverish state. Takeaway from this is understand that any child under the age of 6 months should not have a fever. If you find a child under the age of 6 months with a fever, this child gets an admission to a neonatal intensive care unit and is given what's known as a septic workup. Their blood is drawn to see if there's a blood infection. So fevers in children really don't go well. You see them more predominant when they turn a year or 2 years. You'll see those high spike in fevers, but they can't control them, and the way the body controls breaking fevers is through seizure activity. Just because a child has a febrile seizure does not mean they have chronic seizure disorder, but they need to still have their ABCs assessed, and they need to go to the hospital. Because you don't know, this could be something as mild as a flu virus, dehydration, but it could also be as serious as meningitis. So any case of suspected meningitis, usually it involves fever with a rash of the lower back. So emergency care should be supplemental O2, artificial ventilations if required, and rapid transport, and notification at the hospital you have a possible meningitis case coming in, so there can be, the patient can actually be sequestered and isolated. With the GI system, we have abdominal discomfort is common. Children complain of belly aches, and once again, it's very general and non-specific pain, and it can involve all different organs. You have no idea. So once again, these patients need to be monitored, make sure the ABCs are good, and they need to be transported for further testing. The musculoskeletal system is still forming. The bones are not as strong as an adult bone. They're more pliable and supple, and they're more susceptible to a fracture known as a green stick fracture. So it's an incomplete fracture, kind of like when you snap a branch. It doesn't completely snap off, but instead portions of it stick out. That's that green stick type of fracture, or a spiral fracture, which would be a sign of possible abuse. So patients who have these types of musculoskeletal injuries, they need to be evaluated at the hospital, and you may need to follow up and find out if they are in fact victims of abuse. The skin, very prone to hypothermic events. Just understand that even though children are smaller than adults, their body surface areas are larger. And if you look at a child, think about that cartoon South Park. Big heads, little bodies, stubby little legs and arms, okay? So the big heads account for 18% of the body mass. So where do we lose our heat predominantly? Through our heads. So a child can become hypothermic very quickly if their face and head is exposed to the environment. When we're doing our assessment on a child, it's sometimes better to assess from a distance. And what we incorporate is the pediatric assessment triangle. This is a great structured 15-second assessment tool that you can incorporate. Children are hyper aware of their surroundings, or at least healthy children are. So you ask yourself, have you ever been able to walk into a room and sneak up on a 2-year-old? No. If you are, this child is not aware of their surroundings. So you have to watch a child from a distance and check things like their appearance. Are they able to recognize that you're in the same room with them? Not only are you a stranger, you're a stranger with a lot of cool things hanging off your body. Radio, flashlight, all these crazy stuff that they've never seen before, but they're fascinated. So they should be fascinated by you. That's part of their appearance. We want to see how they're breathing. That's their their effort to breathe. And then what color is their skin? This is the pediatric assessment triangle. You don't need equipment for that. You just walk up and look. Your eyes will tell you everything. So look for the appearance. Look at that level of consciousness. Now, if you look at the picture of this child does not have an appropriate level of consciousness. They are not hyper aware of their surroundings. Instead, they are introverted. Their conscious level is diminished. So what we use is the Tickles mnemonic. What's their tone? What's their interactiveness? Are they crying and inconsolable? Are they looking at you or just gazing in one direction? And are they talking or crying? These are all things that you want to put into your appearance assessment. And now look at their work of breathing. Children don't use sternocleidomastoid muscles because they're not fully developed. They're not going to be really tripoding. but instead they're going to be using abdominal muscles to breathe. Or with infants, they're going to be doing sternal retractions, where you can actually see the sternum suck into the chest. Now, while adults get diaphoretic faster than children, children get cyanotic faster than adults. So looking at a child's extremities, checking for cyanosis is an important part of circulation. And it should go hand in hand with your capillary refill assessment. So from these findings that you can do at 6 to 10 feet, you can make a decision whether this patient is unstable or stable. Are they sick or are they not sick? Should we load and go or stay and play? What is wrong with this patient based on that PAT? Once we walk up and we're going to do our hands-on ABC, we follow the same pathway as an adult. Airway, breathing, circulation, check for disability, expose any areas of injury or trauma. So dealing with children is a situation where you can do an assessment from afar, get the whole picture and look, are they making eye contact with you? Are they receptive to you? What's their effort of breathing? And what color are they? These all can factor in whether this is a sick child and we need to do our assessment en route, or this is not so much a sick child and we can stay and get more of a story at the scene. Now, talking about as we get older, now as a young child we're building, we're growing. As older person, we are starting to dip off and things are starting to break down. And these chronic diseases that each body system is battling can have an overall effect on the organism or the patient themselves. Some frequent conditions that they find, some chronic issues with the elderly. They have issues with their blood pressure. They get atherosclerosis or hardening of the arteries, and they end up, and this inflammation can cause hypertension, chronic. They have respiratory issues, COPD, if they've had a history of smoking. Remember, smoking was very, very accepted 30, 40, 50 years ago, where some doctors actually said it was healthy for you to smoke. So now what we're dealing with is a population of ex-smokers who are suffering from emphysema, COPD, plus workplace conditions weren't the standard that they are now. So they were exposed to elements like asbestos, they've developed mesothelioma. There's a lot of respiratory issues in this elder population of this generation. In addition, we have joint diseases like arthritis, cardiovascular disease. And you can see the leading cause of death: heart disease, diabetes, COPD, trauma. Assessing these patients, there are issues. There's communication issues, the ability for them to hear you properly, understand what you're telling them, extreme medical histories, complicated, where they hand you a bag of medication. You know, we're not here, especially in the acute setting, to try and piece together everything that's going on. So you need to understand that as an EMT, you have to still focus your overall approach, your universal approach to all patients the same way. All right, find out what the chief complaint is. Understand that they won't have those classic signs and symptoms. I have crushing chest pain radiating down the left arm, going up to my jaw and my back. You know, they can just sometimes, when they're having an MI, be short of breath. They have lost the ability to have a really good, profound nerve system in place where the brain can interpret pain signals. Vital signs, once again, they play an important role, but there is no such thing as normal in this age demographic. Some of them are hypertensive, some of them are normal tensive, some of them are normal tensive because they take a slew of medications to prevent hypertension. So we don't know what is normal tensive states for these patients. A lot of times these patients will base their decision to go to the hospital on their blood pressure. So if they ask you that question, well, what's my blood pressure? Well, it's 190 over 100. Is that good? Well, I don't know. Do you know what your normal blood pressure is? Very rarely would they know that. So you can tell them, this seems high to me, but we won't know until we get to the hospital. Make sure that your approach is always going to be, this is part of the hospital process. You don't want to have these patients refuse treatment. You don't know what's going on with them. Heck, they don't know what's going on with them. Their diagnostic centers are breaking down. The disease processes of all of their different organs and organ systems are affecting the overall general health. So you've got to be very careful. That blood pressure is going to be a little higher than normal, sure, but it could be very low. If they have a 130/70, that looks normal to you, but that could be extremely low to them. So be sure you do a good, thorough assessment of these patients. Now, one way that the National Standard Curriculum is created to help you with your assessment is they use something known as the GEMS Diamond. Now, a GEMS Diamond breaks down to geriatric. Older patients present atypically. That one is different from the other. There's no typical geriatric assessment. There's an environmental. Look around the patient's house and look for signs that they are able to take care of themselves. Things like fresh fruit tell you that they're getting outside, or they have connection with the outside world. People are delivering things to them. Also, it helps with their diet. But the no presence of fresh produce can lead you to think that they don't get outside, that they don't have any societal attachment. With the medical assessment, get a thorough medical history. If you have a slew of medications that come in a bag, chances are it's written down somewhere. And if it's written down somewhere, it also tells you that they're following up with their care. Look at that social assessment, put it all together. Are they receiving care with either family members living there in the same house, or are they getting professional care? Nurses, aides, LPNs, RNs, do they live in an assisted living facility where they have round-the-clock nursing care? So these are all questions you want to find out. You know, and you can look at this. It's in your textbook. What's your environmental assessment? You know, are there hazardous conditions? You know, unventilated areas. And you know something, if you go into someone's house and the house looks like it was from a museum, it hasn't been touched. The living room has not been touched. The dining room is pristine. But the bedroom is a mess. And you know that this person has issues with mobility. They live in the bedroom, they can't get out. These are all clues that you have to take in. So let's talk about different systems and what happens when they break down and some things that you might encounter. So understand that when you get older, everything breaks down. So just keep that in mind when we're talking about this. So when you get older, the alveoli, there's millions of alveoli, you start to lose 10%, 20%. You know what ends up happening? You lose 10 to 20% of the ability to get oxygen into your body. The structure, the bronchioles, the bronchus, the trachea, they start to weaken as well, and you lose the ability to cough, so you develop mucus that can't get out, it's trapped, and it drops down instead of going up, and it becomes infected, very prone for pneumonias. They're very prone for pulmonary embolus, especially if they suffer from irregular heartbeats like atrial fibrillation. The irregular heartbeats in the atria are fibrillatory, so they're quivering back and forth, and that quivering creates clotting. And the clots can travel to the ventricles and up to the lungs, and we end up with a pulmonary embolus. These patients are at risk for atherosclerosis and accumulation of fatty material on the arteries, and this is going to put a stress on the cardiovascular system. In addition to risk of myocardial infarction, they also have a risk for stroke, non-traumatic brain injury. Blood vessels through the atherosclerosis become stiff, heart valves degenerate, the heart rate can be affected by medication and be too fast or too slow, and get in the way of good pumping and cardiac output, which is going to affect blood pressure. Another problem we call venous stasis. So the veins in the legs can't carry blood back. The blood stagnates, loses the ability to go back up. Veins have one-way valves on them. And what that does is it prevents blood from dropping back, having gravity take effect. These one-way valves, they pump open when the blood pushes up, and they close to prevent blood from going back down. When you get older, these valves start to fail, and we end up having blood stay lower. Plus, these patients are not as active. The process of walking increases venous circulation because the muscles encircle veins, and when you move your legs, you contract the muscles, it actually moves blood up to the heart. That's why walking is good for your circulation. When you get older, you're bedbound, or if you are in a wheelchair, you're not able to use that type of circulation, and we get stasis. Myocardial infarction, remember, it cannot be that classic one. Don't look for that classic. Any patient who is sudden shortness of breath for an unexplained reason, they got dizzy and they have shortness of breath, they could be having a myocardial infarction. If you request advanced life support for an elderly patient complaining of sudden onset of shortness of breath, and this patient probably is going to need an intensive EKG, a 12-lead EKG, and could end up going to a STEMI center just based on their shortness of breath with a positive finding on a 12-lead. But we're only going to find that out is if we call paramedics and get ALS intervention. So in addition to the shortness of breath I mentioned, they can have abdominal pain, they can be nauseous, dizziness, fatigue, and sometimes confusion, a sudden onset of confusion. So for these patients, you want advanced life support on the scene so we can do a little more in-depth monitoring of their cardiovascular system, such as a 12-lead EKG. Heart failure is the heart's inability to pump blood effectively to the tissue, to get oxygen delivery to the cells. Risk factors of this failure is that causes the damage to the pump is hypertension, increased resting pressure of the cardiovascular system, known as diastole. So any blood pressure, diastolic blood pressures above 90 is considered to be chronic hypertension. This excessive pressure is going to put more pressure on blood coming back to the heart, pounding against the heart. The heart is going to get diseased in an effort to try and ward off that high pressure, and we're going to end up with congestive heart failure. Now, talking about the nervous system, when we talk about dementia, dementia is a structural abnormality. It's brought on by destruction of brain cells. And it's really the cause of it is unknown, but just knowing that the brain itself has now started to eat away at itself, literally. And it's built up plaque that's getting in the way of impulses being traveling from brain cell to brain cell. It causes confusion. It sometimes changes the personality of the person. That's what you find in diseases like Alzheimer's disease. So patients with dementia, you're not really going to be able to interview them and assess them properly. So once again, they are asking for help. Either they've called you or a family member's called you, primarily a family member or a caregiver. There's a problem, there's an acute problem, that they have a chronic mental issue. So these patients cannot make an informed consent they need to be transported to the hospital for further care and evaluation. Delirium is a sudden change in mental status, whereas the patient had a normal mental status, was alert and responsive. Now suddenly there's a problem. This can be triggered by something as benign as acute anxiety. But it can also be brought on by drug or alcohol intoxication. Sedative withdrawals, when lots of times families or patients can't afford their medication and they stop taking them. They don't understand the medications that they're supposed to take versus not supposed to take, and they make these decisions against or even without the doctor's knowledge. It can have serious side effects, so you need to be aware of that. So when you're assessing these patients, of course, think about airway management. Think about your ABCs: hypovolemia, hypoxia, and hypoglycemia. These are the three major causes of acute change of mental status. And we can correct them. Something else that happens when we get older is the body can't compensate as quickly to changes in environment, atmospheres, from sitting to standing, and it can cause a sudden loss of blood pressure, which is known as syncope. You have to make an assumption that if a patient passed out, was unarousable, and now they're fine, we don't know why they did that. It could be a slew of things, and the only way we're going to find out is if we go to the hospital and have further testing done. So a breakdown of the cardiovascular system can lead to a stroke, which can then cause a structural problem with the nervous system that can cause chronic issues, neurovascular issues, and death. There's preventable risk factors like too much cholesterol in the blood or chronic hypertension. But you can also have uncontrollable risk factors, like a sudden hit of atrial fibrillation can cause clotting that will pass from the left ventricle and go up into the brain. Disorders of the nerves where they start to break down and they lose the ability to communicate with one another, that's known as neuropathy. And what happens, signs and symptoms of that is patient loses the ability to understand and process pain. In addition to not being able to process pain, they can sometimes feel a lot of excessive tingling, they feel itchy, and they also, on the motor end, they have muscle weakness, they get cramping, spasming, they lose their coordination ability. So these nerves can't process sensation or motor function effectively. That's on the somatic nervous system or the voluntary nervous system. On the autonomic or the involuntary nervous system, which controls your cardiovascular system, your respiratory center, your digestion, there's changes in that. The body can't regulate blood pressure effectively, they can't regulate pulse rate, it's hard for them to digest properly. There's a lot of issues on the autonomic side with neuropathies. And we talk about gastrointestinal, being able to digest properly. We slow our ability to draw nutrients from the chyme that's created by the acids, base, the acids and alkalis, and enzymes that have broken down the food. And this chyme that's now going through the small intestine, the body can't absorb what's in there, so we end up with almost a sign of like malnutrition. So a lot of these patients go to like liquid diets are more easily digested. Also liquid diets, they will be lessen the risk of having bowel obstructions. So in general, if we have a rupture of a vasculature, we're going to end up with things like bloody vomitus or dark tarry stool, indigestion, and enlarged liver. All these things that are getting in the way of the digestive processes, and we have some bleeding that occurs, and this could be a serious emergency. And some contributing factors to this is use of alcohol and some over-the-counter meds like Motrin, NSAIDs, non-steroidal inflammatory anti-inflammatories. These are drugs that can cause bleeding, intestinal bleeding. And if the body is already sensitive to that, if lost the ability to protect the arterioles and the veins around the small intestine, we're going to have a problem with internal bleeding. The renal system, if we're talking about the kidneys start to lose the ability to produce enough urine and get rid of the waste products of cellular metabolism, like urea, creatinine. They lose the ability to get rid of those. And whatever's left over, if they're able to create urine, we have incontinence because the bladder isn't able to stay constricted until voluntary evacuation. The opposite of the incontinence is difficulty urinating. And in men, you're going to end up with that enlarged prostate that's going to restrict flow of urine from the bladder, and that could be an issue. With women, you're going to see an increase in urinary tract infections because the external genitalia can't still produce that same acidic environment that protects against the bacteria, and it becomes more susceptible to bacteria forming. Plus, wearing support garments like diapers can also be a breeding ground for organisms that can cause urinary tract infections. Go to the endocrine system. Hey, it's not going to get any better here also. I mean, you're going to lose the ability to produce insulin, therefore the sugar is going to stay outside in the vasculature. The insulin won't carry sugar across into the cells. That can be used for energy production. So diabetes type 2 is a predominant endocrine disease among the elderly. And you can see this signs of increased sugar in the blood. The body can't use that sugar, so it starts burning fat instead. And the process of ketoacidosis that occurs, you're going to see that polydipsia, polyuria, polyphagia, dizziness in addition, and the patient will display that DKA, classic DKA, but they've got no history of diabetes. Well, guess what? Age has brought on type 2 diabetes. When women run out of eggs and they enter into what's known as menopause, they don't produce estrogen and progesterone as a result. And one of the duties of estrogen is to help in retention of calcium. So they can't produce calcium from an external source, so they take it from the internal source, which is the bone. And in the bone, they withdraw the calcium, and that leads to bone that's not as firm, it's spongy, and that's known as osteoporosis. In addition to those hormonal issues, we have issues with, could be a genetic predisposition, alcohol consumption can lead to osteoporosis in menopausal women, and their level of activity. Sedentary activity can also lead to not getting outside in the sun where you have the calcitonin that converts into vitamin D is predominant in causing that bone loss, bone mass loss. The joints in between bone, they run out of that cushioning agent, the synovial fluid, and they instead begin to inflame, and we end up with osteoarthritis, inflammation of the bone and joint. With the skin, skin is pliable and elastic in nature, and the elasticity of skin is known as collagen. And when you get older, you lose the ability to produce collagen, and as a result, your skin gets thin and loses its elasticity. because it loses its elasticity and it's thin, it's more prone to ulcering. And these ulcerations are known as decubiti sores. Also, these patients are bedbound, and if they stay in one position for more than 8 hours, they can develop inflammation of that area of skin that's compressed between the bed and the bone. So they need frequent turning in bed. This is one thing that nursing homes are supposed to do. Nurses come in and do bed turning every 3 to 4 hours to prevent these ulcer sores. And stage 1 is the early onset, where you see some redness. There's still damage under the skin, but it's an inflammation that can be corrected if you give some antibiotics and you remove the pressure. Stage 2, we start to have blistering. Stage 3, it goes into the fascia. And stage 4 decubiti ulcers, actually, it's an invasion into the bone in some instances. And some sacral decubiti ulcers, you've been known to be able to stick your fist inside. And once again, what's done with that to correct it, they actually have to pack the hole that's been created. It can lead to sepsis, septicemia, and death. Now, toxicology is a big thing because the liver is not able to process, break down, and filter out all of those byproducts. As a result, when patients take prescribed medications, their levels will change. The liver will allow more of the drug to pass into the systemic circulation, and they can have more toxic levels as a result. Now, over-the-counter meds that you experience with geriatric patients include the aspirin, the NSAIDs, nasal decongestion, cough syrups. These can have a negative effect on prescribed medications that they are taking. But a lot of these patients undergo what's called polypharmacy, where they'll have many doctors prescribing many different medications, and these medications can interact with each other. But one doctor doesn't talk to the other, and they don't understand the full history of the patient, and this can lead to some toxic issues. These negative effects of overdosing can have a negative overall effect on overall health. In addition, these patients pick and choose which medications they're going to take each month. If they take a total of 15 different meds, they'll choose, I'll take these 10 this month, and I'll take the other 5 the next month. That's not good, because they lose levels in their blood chemistry that affects their normal balance of life. With the elderly, psychiatric emergencies you have primarily depression. High suicide rate in the elderly. And the risk factors, of course, they lose a lot of their friends. There's a loss of social networking. They also lose the ability to function. The chronic diseases that they have to deal with on a daily basis are debilitating. And sometimes they feel like suicide is the only answer. With trauma, they're not able to compensate as well. A lot of times, outside of structural diseases or disease processes, medications that they're prescribed will get in the way of compensation. If they take beta blockers to combat hypertension, and now suddenly they're a victim of trauma and there's blood loss, they can't compensate. The epinephrine that's used by the sympathetic nervous system to increase heart rate and blood pressure is not going to be processed because the beta blocker is on board. So these are issues. So patients don't present classically like younger patients. There's perception issues. A lot of elderly patients get involved in horrific car accidents because they lose the ability to take in senses around them, which is vital for driving. Also structural issues like impairment of meds, equilibrium problems, diabetes, sudden onset hypoglycemia can all contribute to car accidents. Most common mechanism of injury, though, are falls. Okay, and it can be from an environmental issue, like area rugs or loose floor coverings, and other physiologic issues like loss of visual acuity, cardiovascular issues where they syncopize. Even falling from a standing position can end up being a serious injury. Burns are very common because they lack the ability to have that reflex arc working effectively. So they'll touch a hot stove and not realize it's hot, and they'll keep it, even if it's a split second longer than a younger person, the effects of the burn can be substantial. Penetrating trauma, gunshot wounds, the body cannot repair itself as effectively as it did when it was younger. We have to be cognizant of elder abuse and neglect. There are some states where you are mandatory reporters for elder abuse. You have to review with your individual regional protocols exactly what to look for and how to make notification, but you still have that general approach. Basically what it boils down to is any action of a person by their family member, a caregiver, where they take advantage of taking their property, taking their Social Security money, or affecting their emotional state, isolating them, locking them up, not assisting in their care, can be deemed as abuse or neglect. It's very hard to see this. It's sometimes overlooked. Patient is always very angry, and they're very hard to deal with. Some people enter with the best of intentions. Can good people abuse the elderly? Absolutely. They try and do the best thing for their parents, and they realize that this is a real challenge, and they can lash out in frustration. They may not be professional caregivers. But even professional caregivers it can be too much for them. So understand that there is it goes across all socioeconomic boundaries. Okay, so you can't just look at the environment to determine if neglect's taking place. Get a good assessment. Find out what happened. Suspect abuse when people aren't forthcoming with information. Why aren't they forthcoming with information? I mean, you're here to help them. Okay, are they trying to hide something? Is it in their best interest not to communicate with you? These are things that you want to process but not accuse. These are things that you take in as part of your assessment scheme and then pass your findings on to either law enforcement, hospital personnel, or social services, so something can happen. Because this neglect can solely be because the patient is far beyond, their needs are far beyond the ability for the caregivers to handle, and they may need something as simple as some professional help, assistance, that can make all the difference in the world. You know, things you want to look for. Have they been to the emergency department for the same complaint over and over again? Are they quote-unquote accident prone? You know, do you see, just like with pediatric abuse, are you looking at bruising and different forms of healing, different stages of healing? Is the patient displaying self-destructive behavior? What's their underlying mental status? And these are things that, once again, you only suspect abuse and neglect. You'll never accuse anybody. It's like playing Clue. You can suspect that Colonel Mustard did it in the kitchen with the candlestick, okay? If you accuse Colonel Mustard and you're wrong, game over for you. If you accuse people of abuse and neglect and you're proven wrong, that's bad. That could be the end of your career. So you need to just say, you know, I suspect this is true, and pass your suspicions on to law enforcement or the hospital, and let them do the investigation. You know, we talk about bruising. Bruising can occur anywhere, but things that would make you suspect abuse: the buttocks or the genitalia, cheeks or the earlobes, places that won't readily be bruised as a result of a fall. Burns with cigarettes or heated material, chemical burns, these are classic signs of abuse. And look for signs of neglect. I mean, you just do this assessment. And while, okay, from this picture you might see some things, it doesn't tell you everything that's going on. This could be a patient who is fine, operates fine. They just don't have the economic ability to pay for kitchen repair. It doesn't mean that they're being neglected. Take it all into perspective. So we're talking about the very young, from birth up until the elderly, geriatric population, when things start to break down. We work in a society that, as far as medicine goes, it's growing at an exponential rate, our technology. We're able to do incredible things, and with this incredible technology comes its own special challenges. The fact of the matter is, you need to stay focused on your universal approach to assessing your patient and giving optimal patient care. Don't be intimidated by all of this new technology. So what's assisting? What technology assists? We have things like developmental disabilities, insufficient cognitive development of the brain. Possible causes could be genetic, birth defects, malnutrition. I mean, a lot of different things that happen either in utero or at birth can lead to developmental problems throughout life. These patients either live alone, or they have family or caregivers, or they are institutionalized. Get information about the patient from all sources. A very common developmental disease right now is autism. And there are different grades and levels of autism. From the very mild, where there's societal interaction issues, to the severe, where there's absolute nonverbal abilities, no communication with the outside world at all. So the very mild one with the communication is usually treated at home, and you have some extreme ones, like Asperger's syndrome, where the child can actually be violent. You have to be careful. Don't know why autism occurs, how it manifests. Is it an issue with prenatal care? There's all different theories out there, but there's no definitive reason as to why. There's new methods that can diagnose autism at 2 months, but right now the accepted medical practice is about 3 years. Down syndrome is a genetic malformation caused by a chromosomal defect. And what ends up happening is there are structural abnormalities, like the round head, slanted wide set eyes. And this is a major challenge structurally, because we have problems with airway management with Down syndrome kids. A jaw thrust maneuver may have to include a nasopharyngeal airway. So these patients are in the resuscitative arena are very difficult to manage because of their airway complications. When you're interacting with these patients, either autistic, Down, you want to just treat them like anybody else. You're their friend. Be a little bit more friendly than you would a normal person. Approach in a calm manner. Talk to them. Try and soothe their anxiety and discomfort. They don't want to be spoken to like a baby. They want to be spoken to like an adult. But you're going to speak maybe a little bit slower and a little bit nicer. Not going to be firm in your voice. You're going to be more compassionate. patients who are recovering from traumatic brain injury or non-traumatic brain injury. There are problems depending on the location of the brain that was damaged. Find out what normal is for this patient. High-tech patients like these usually have high-tech parents. So this is a situation where you want to get the parents involved and have them on your side. They're going to be a wealth of information, and they're going to be able to tell you what's normal and what's not normal, why they called. So some sensory disabilities we have with sight, congenital reasons. It could be a disease process like glaucoma. It could be brought on by an injury, degenerative issues. With hearing, could be impairment to total deafness. We still do emergency care regardless. You know, we might have to focus more on tactile than on voice or sight. Some neurologic issues we have, cerebral palsy. This is usually developed during gestational phases in utero. It can also be brought on by traumatic brain injury. After birth, children who develop a fever, I mentioned earlier, any child under the age of 6 months with a fever should be immediately taken to the hospital, because one of the side effects, one of the end results of this type of infection, it can lead to cerebral palsy. And with this, you lose, by palsy, you lose the ability for the muscles to work properly. In addition, you can have some visual or hearing impairments, and there's a communication lapse. You can also have mental retardation. There can be constant seizures in some cases. It's a very, very serious, debilitating, chronic issue. So with people with cerebral palsy, not all of them have mental retardation. So find out the history. What is normal for this patient? Why are you here now? Don't get focused, caught up on the disease. Focus more on what is going on acutely. Okay? Understand that equipment is made for the patient. The patient is not made for equipment. So you want to have your equipment meet a patient's needs. So padding is big. You don't want to move this patient into an anatomical position. So things like if you have to immobilize somebody with cerebral palsy, you want to really pad the longboard. You want to put them in the functional position, not make them normal or your definition of normal to fit your equipment. Spina bifida, this is a true birth defect, usually recognized in utero. It's an incomplete closure of the spinal column and the tissue that forms around it. This can be closed surgically, but there's severe spinal cord damage. A lot of these patients don't really survive past their teenage years. They will have associated complaints like hydrocephalus, where there's excess fluid in the brain, and this shunt that's placed actually drains the excess cerebrospinal fluid. Paralysis can occur, loss of bowel or bladder control. One thing to take away from this, very interesting, what we found out is spina bifida patients primarily have a terrible latex allergy. So when you're treating any patient with spina bifida, you want to use the non-latex, the nitrile gloves. What is paralysis? Well, it's the inability to voluntarily move body parts. And you can have sensation, and this is an interesting thing. Paralysis means loss of motor function, not sensation. A lot of times these patients can have extreme pain sensation, where they actually have surgery to correct and transect the spine so they lose all sensation. So if you come across a car accident victim who's telling you that their legs feel like they're on fire, there's a very strong possibility that they have a spinal cord injury. and depending on where the spinal cord injury is located, will tell you what body systems are able to be used and what cannot be. So if they're high up in the cervical spine, they lose sometimes their ability to breathe, so a lot of these patients will be on a ventilator. They also get specialized equipment to assist in their everyday function, since their body can't coordinate that anymore. They have urinary catheters, they'll have tracheotomies, colostomies for fecal absorption and excretion, feeding tubes. They may need to be suctioned constantly. It's a very challenging way to live, and it's a challenging patient to transport and handle. In addition, we have our bariatric patients now. Obesity is defined as excessive body fat. We don't really understand what causes obesity, truly causes. It could be genetic, it could be diet control, there's all different things that can cause this. But the fact is that these patients are under extreme stress for daily function. Severe obesity is 50 to 100 pounds over what we classify as ideal weight, body mass index. And with this, because the body is under extreme stress because of the excess weight, it's more prone to diabetes, hypertension, cardiovascular disease, and stroke. When you're dealing with these patients, you want to interact with them in a professional way. Find out what normal activity is for them. What are they normally able to do? Coordinate movement. If you challenge your body to lift this patient, you will end up with a back injury. You have to coordinate with groups of people. You need, the more people you have to assist, the better. Remember that most of your equipment, unless it's specialized, cannot accommodate obese patients. I mean, your stretchers, some stretchers can only manage weights of 800 pounds or more. Look at your stretchers to see what weight limits there are, because you may not be able to raise them. Look for pinch points on your stretcher. Make sure that it doesn't interact with the patient. When we're transporting out to the ambulance, we got to look at egress routes. How are we going to get out of the house? We might have to create an egress route. That's when the fire department comes and cuts holes in the wall to get the patient out. Now, I earlier talked about tracheostomy tubes. What are they by definition? They're the entry point for air to get to the trachea, in the form of a plastic tube put into a surgical opening. Now, you can have temporary trachs for patients who have been admitted to the ICU, and then they've recovered, they've removed the trach, the membrane closes, and they're able to breathe. Or we can have permanent tracheotomies when we talk about spinal cord injury patients, things like that. So these tracheostomy tubes are foreign to the body. So the body will react, and there can be periods of inflammation. There can be an allergic response. But really what happens primarily is the body forms mucus around it to protect itself from it. And these mucus plugs can actually obstruct. To recognize any obstruction, you have to incorporate what we call the dope mnemonic. So if it's not working, if you're ventilating, if you've got the patient on a vent, and it's firing and suddenly the alarm triggers, incorporate your dope mnemonic. Why is the alarm triggering on your ventilator? First thing is D. We could have tube displacement, dislodgement, or damage. Okay, so what are we going to do? We're going to check to see if there's a mucus plug. We might want to suction or push some saline down there to clear the obstruction. If that doesn't work, and the obstruction not cleared, then we got to think about pneumothorax. Listen to lung sounds. Do you hear lung sounds on one side and not the other? That's potentially a pneumothorax. What was normal for the patient before you left, before the alarm went off? And then if that doesn't work, it's equipment failure. And if that's the case, you turn off the ventilator and you go to manual, which is a bag valve mask, or a bag valve over the tube. Okay, and that's basically what it is. If with high-tech problems, there's always a low-tech solution. We use mechanical ventilators, so we don't have to manually ventilate. These are for patients who are not able to breathe on their own. It's nothing to be scared about. It's very easy to handle and to manage. It's going to be part of the emergency medical technician standard of care practice. It's your scope of practice now, knowing how to use a vent. Become familiar with the equipment at your agency, and you just match the settings that you find at the hospital. And the things that we're concerned about are tidal volume, the amount of air being pumped in with each breath, and the respiratory rate. How many breaths per minute? If you have failure of it, think about that dope pneumonic. Was the tube displaced? Is it obstructed? Is there a pneumothorax? Or did simply the equipment fail? If it does, we go to manual. We have the BVM, or if the patient is breathing normally and you want to, they're breathing through the tracheostomy and you want to assist with their breathing, with their oxygenation, then using the mask to stoma method is still acceptable. Children on apnea monitors, and what these are, they have a history of SIDS, or they've had a SIDS in the past, or the family has a history of SIDS. They're put on there that actually send an alarm when the child stops breathing. It can be used 2 weeks to 2 months after birth to monitor. Child had a history, or a family had a history of SIDS, the child goes on this monitor. It encircles the chest, and when the child moves, it triggers it to stay the same. It's very similar to, firefighters know that they have their movement alarms on their Scott packs, and when they stop moving, it triggers. It's very similar to that. CPAP machines used out of hospital for sleep apnea, it's forced pressure. Every time you take a breath, it forces air into the lungs. It's excellent for sleep apnea in the chronic setting, but also by forcing air in, it's great for pulmonary edema in the acute setting. Internal pacemakers, they're implanted under the skin, usually on the left side now, because the right side, if we have to put pads on for defibrillation, having a pacemaker get in the way, make sure that it's no less than 2 inches away from a pacemaker, putting a pad. What we're finding now is people who had heart failure, who were in cardiogenic shock, instead of getting a new heart on a transplant, they are receiving an assist device called an LVAD, or a left ventricular assist device. And these LVADs actually assist the left ventricle and suck blood out and increase cardiac output and therefore restore blood pressure. Issues with LVAD patients is that, first of all, they don't have a pulse anymore. The pulse is gone. They have a whoosh that comes from the LVAD. You don't feel it as a pulse or blood pressure. The other thing is that they carry this LVAD around with a battery pack. So it becomes an issue of transporting them. Now, most of them are portable, and it's not a problem. They get around, they understand how it works. But realize that while they're waiting for a new heart, they're on this left ventricular assist device. It keeps them on the heart transplant list a lot longer. Some have a permanent LVAD placed. This is the new science. So these high-tech patients, remember, when there's a high-tech problem, there's a low-tech solution. If they go into cardiac arrest, you can still do CPR. patients are going home now with central venous catheters. These are long-term catheter placements. When paramedics put an IV in place, it only should be in there for 24 hours before it's changed. That because of the risk of infection. These central venous catheters are much longer. They're about 2 feet long, the catheter. And that allows for a longer placement, can last up to 2 weeks. And they give good access point for medication. Now, common problems, they get obstructed. The lines break, there's infection around there, and bleeding. So once again, if you're going to treat it. If it's bleeding, we're going to work on direct pressure to try and stop bleeding, and this patient needs to be transported because this is a surgical consult. Gastrostomy tubes, you see this a lot in nursing homes. This is how patients are fed. It's enteric. Food goes right into the stomach, into the small intestine, and is digested much better than being able to chew and swallow. Patients who can't do that are given these types of tubes. Problems with gastrostomy tubes is they can get dislodged. So we want to assess for abdominal bleeding. Are they having discomfort? Are they vomiting blood? There's a high risk for aspiration, so the patient should be sitting at least a 30-degree or semi-Fowler's position. I talked about shunts earlier for hydrocephalus. Shunts is a tube that's placed into the ventral center of the brain that drains excess cerebrospinal fluid. Too much cerebrospinal fluid will put pressure on the brain. And we have different types. We have the ventricular peritoneum shunt and the ventricular atrium shunt. Do you need to know the difference? You just need to realize that with shunts, they can become blocked or sometimes infected. Where do you see shunts? They're inserted internally, but there's an external component where the fluid drains into. It's usually found on the side of the head behind the ear. Signs of distress in children, they'll have bulging fontanelles, headache, signs of increased cerebral swelling. New treatments for seizure disorders, patients who have chronic constant seizures, like we find with our congenital problems or with our disease processes. These patients are on vagal nerve stimulators, and this is an alternative to medication. And it's located under the patient's skin. It stimulates the vagus nerve of the parasympathetic nervous system that prevents seizure activity from occurring. So if you have a patient with a vagal nerve stimulator, once again, it's not going to be dangerous to you. The stimulation is mild and it's internal. If it's failing and the patient's seizing, you need to notify the hospital that this patient possibly has a vagal nerve stimulator that's not working effectively. If you lose the ability to defecate, you have a colostomy or an ileostomy. And all it is it's a creation of a little incision right at the end of the small and beginning of the large intestine, and a bag is placed. So the fecal matter, instead of going into the large intestine, will end up collecting in the bag. But realize that area is highly prone for infection. That's a dangerous product that's being filtered in. So once again, high-tech patients, we can have low-tech solutions. Find out why you're here. What's their normal status? Get it from the caregivers. There's a reason why the caregiver is called. Okay? And don't get focused on the high-tech issue, because maybe that is functioning appropriately. Maybe their colostomy bag is working, but they're having respiratory distress. We're going to see more and more of the next coming years, more and more home care, less hospital, extended hospital stays, and more home care visits. And you're going to be called to someone's home chronic patient who's being cared for by a home care provider. In addition, we have hospice care. These are terminally ill patients who do not have any hope of recovery, who are now being given supportive care by nurses and aides. And one thing you're going to see with these patients, they're going to have paperwork in place, they probably do not want CPR done, and they're going to have high levels, doses of opiates. Morphine is going to be a predominant drug in the hospice setting. And all this is part of comfort or palliative care, just to ease pain, not to cure, but to make their last days or weeks comfortable as possible. Follow patient's wishes with do not resuscitate orders. In New York State, we have the MOLST form, medical orders for life-sustaining treatment. These are things that we want to look at, so we need the paperwork so we can honor it. You don't honor verbal DNRs, you don't honor verbal MOLST directions, you need to see it. But while we're doing that, show compassion. They could be panicking, say, all right, fine, we're gonna have to start CPR, but please give me the paperwork, and as soon as you show me the paperwork, I can stop, I'll call the doctor, and we'll stop everything. If you're going to the hospital, make sure you bring all your documentation with you. What are not only the patient's wishes, but also try to incorporate the family's wishes. If the family's wishes go against the patient's written wishes, explain that this is what the patient wanted. Be professional. If you're still having a problem and the family is adamant that they want care, sometimes it's best to act in that interest, because the people that survive, the closure is going to be more helpful to them, if at least they saw you trying to help them, help their loved ones. Another special need population we have is the poor and the homeless. These people are unable to provide their basic needs. And understand that a homeless population, some of the sickest patients you're going to encounter, they have a wealth of medical issues. In addition to having their underlying mental health issues that can be prevalent, they'll have a lot of different functional problems through smoking, heart disease, GI disturbances, alcoholism, lots of problems. These patients need to be cared for just like any other patient, and they need to be given emergency care. Become familiar in your local area with homeless shelters and what type of care they have. There are some systems that have homeless advocates that go around the city and find homeless people they determine to be in distress, and they call 911. You need to work with them to assist, because their goal is to provide help. That should be your goal as well. So that's the common ground that you can meet them on. So there are different types of patients you're going to find. There's no cookie cutter classroom patient that you're going to treat. There's all different shapes, sizes, ages, underlying medical conditions, high-tech problems, chronic care, end-stage care. These are all things that you have to deal with as an EMT. And if you just maintain your professionalism and have your overall universal general approach, you will be fine and you will provide the optimal care. Thank you.